Finally, a few additional concepts with respect to screening testing is the yield. This is the amount of previously unrecognized disease that is diagnosed with screening. It is influenced by the sensitivity of the test as well as the prevalence of unrecognized disease in the population. So in screening tests, a high positive predictive value is desirable, as we've discussed. However, if the prevalence of the disease is low in that particular population, even a highly sensitive test will yield a low yield in terms of the positive predictive value. And for most yield, screening should be aimed at populations with a high prevalence of disease. So this kind of goes back to the concept earlier that was discussed, which is in order for a screening test to be useful, there must be some level of prevalence of that disease in the population for whom the screening test will be utilized in order for the screening test to be of use or benefit for the individual as well as for the public health. And so yield is one way we look at that benefit, but it's not the only way. And then the final thing I want to define is the diagnostic accuracy. And this is an attempt to simplify the 4 indices of test validity into a single term. So for instance, the proportion of correct results or the sum of correctly identified ill and well divided by all who were tested. This is not a measure that is used often when we evaluate the validity and accuracy of a test. It's just one other measure that can be calculated. But again, we do generally think of the accuracy and validity of a test by considering the 4 other indices I've discussed in detail, the positive and negative predictive values and the sensitivity and the specificity. Now, I want to talk a little bit about overscreening because, as I said in the beginning, a goal of screening is, of course, to find disease at the subclinical level with the assumption or implication at that point that we're going to deal with that somehow and reduce the overall morbidity and mortality associated with that disease that we're screening. So, but the question is, and it remains for many screening tests that are still used today, which are we really reducing the morbidity and mortality of the disease? Are we improving the quality of life by identifying the disease at a subclinical level and treating it accordingly? And that's a controversial question, of course. It depends on the level and the severity of the treatment that's implemented at the point that the disease is identified and diagnosed. And another question is, does it really reduce cost of disease over time if we're screening for disease earlier and diagnosing it earlier? So here is an important paper I want to summarize by Welsh and Black, published in 2010, and it is essentially about the concern of overdiagnosis in cancer. They define overdiagnosis as a condition is diagnosed that would have otherwise not gone on to cause symptoms or disease due to one of the following: that the disease never progresses, or that the cancer, or it's usually the cancer, or disease progresses so slow that the patient dies of another cause before the cancer would have, essentially become so severe that it was what killed the person. So that's the idea of competing risks, that there is something else that's going to kill the person before that cancer or disease that we're screening for kills the person. So this figure illustrates the proportion of specimens that were found to have prostate cancer. And again, this is among deceased individuals who didn't have clinical prostate cancer before they died. And these specimens were examined post-mortem, and this illustrates the proportion of those specimens by age group of the individual who passed away, who were positive for prostate cancer. And so the message here is that as a person ages, that there is a greater probability that they will have preclinical prostate cancer, and was illustrated in 2 different studies. So the idea being here that there is going to be this existence of a reservoir of preclinical cancer always, and hence if we go looking for it by screening, we could potentially overdiagnose. So that's based on the first criterion of overdiagnosis that they state. And then the other, with respect to activities leading to early cancer detection, they talk a lot about, of course, cancer screening and how that has changed over the past several decades insofar as increased cancer screening and screening for people earlier in life. Another approach that can lead to cancer detection is pathological inspection of tissues that are removed for surgeries for other reasons, but then they're screened and assessed for cancers and they're found to be positive. And that type of approach happens often, and so it leads to this finding of, oh, by the way, you have cancer, you have prostate cancer as well. They talk about the concern of overdiagnosis also with respect to discussing findings from randomized clinical trials. So these are clinical trials that are designed to compare person's outcome when screened for a particular cancer in one way versus not being screened. So they talk about different cancers, and they cite one particular example with breast cancer, and they summarize that there were 9 clinical trials that have been performed to evaluate the effects of screening for breast cancer, and only one of those studies reported long-term results. And what was interesting about that one study is it essentially showed that that even after 15 years of follow-up after the point of the screening, there wasn't a catch-up of the screening of the cancer cases among the controls. And so the idea being that if screening really does not lead to overdiagnosis, that if we screen a person earlier in life and we find that they have breast cancer, say, and we follow them forward, if we hadn't screened them and we follow them forward, presumably if they really have a cancer that's going to become a clinical issue, the person who wasn't screened early will still present with clinical illness after that same length of follow-up. In that one clinical trial that had the 15 years of follow-up, there wasn't a dramatic increase in the number of clinical cancers among those who weren't screened early for breast cancer. And so the authors of that paper and this particular paper here concluded that, again, there's this risk of overdiagnosis, and it was illustrated in this 15-year follow-up for breast cancer. And then they talk about similar results showing overdiagnosis for lung and prostate cancer screening. So the potential harms of overdiagnosis are many. The first is the patient cannot hope to always benefit from detection of what's called an indolent lesion, a lesion that hasn't led to a clinical presentation. There are always concerns about harms of early and unnecessary treatment in someone who has preclinical disease. And then there are clearly concerns of the psychological, social, and economic impact on the individual. And I cite the finding from a particular study here where there was a study of assessing screening workers for high blood pressure. And it essentially found that after the screening was implemented, that there was an increase in absenteeism among persons who were diagnosed with high blood pressure, just by the mere fact they were diagnosed. That affected their ability to come back in, affected their ability to work. And then I finally close with this table, which probably needs to be updated again, but just to illustrate the endless saga regarding mammography testing screening guidelines. And the current guidelines as of 2015 essentially state that breast cancer screening should begin annually at the age of 45, and after the age of 55, it should occur every 2 years. Previous to this, it was recommended that screening begin at the age of 40, and essentially recent data have suggested that there's no added benefit of screening women between the ages of 40 and 45, and essentially it was leading to overdiagnosis.